I would like to make some appeal to the members that our annual conference is on the corner, uh, is approaching uh, fast. So I request all the members to participate by uh, paper presentation, by taking parts in the quiz, joining the workshops. The organizers are taking a lot of efforts to make this conference successful, and it's our uh, uh, duty to make this conference successful and encourage the organizers. The second thing is that the elections are announced and the email is sent to all the members. If somebody has not received the email, please contact me. I will see that he should get some. He will get the information. The third thing is about the bidding of the conference. About this also the email is sent, and with the all the conditions are being mentioned in the email. How to apply for the conference, uh, what are the prerequisites, your connectivity, and all the things are been mentioned in the your letter. So kindly fill that form and send back to me. The email ID is already given to you. And with this appeals, I would like to come for today's webinar. So today's webinar is about the endoscopic spine. The future is here, and we have the eminent speaker, Dr. Jayant Gaud. He will be talking on PSLD for lumbar canal stenosis. PSLD is percutaneous stenoscopic lumbar decompression. The next speaker is Dr. Sumit Pawar from Mumbai. He will be talking on advances in endoscopic spine surgery. And third speaker is Dr. Rahul Aluwalia. He'll be talking on UBE in lumbar canal stenosis, that is unilateral biportal endoscopic surgery in lumbar canal stenosis. This will be followed by discussion. So for this webinar, we have moderators Dr. Dattatreya Majumdar from Mumbai and Dr. Sarang Rutte from Pune. And we have eminent panelists Dr. Dattaprasanna Katikar from Solapur, Dr. Anil Padil from Satara, Dr. Vivek Bonde from Pune, and Dr. Sandeep Iratwar from Nagpur. With this short introduction, I would like to hand over to the moderators, Dr. Dattatreya Majumdar, sir.
Thank you, Milind. And I think this is a very important, although it's an year end, so Merry Christmas and Happy New Year to all of you. I think this is a very important topic because the current trend is changing very fast from open spine to endoscopic spine. And being at Sion Hospital, I have realized now that we are already started doing endoscopic spine in a very big way. So I'm seeing the results myself now on this thing. So I think this is a very novel topic, and there are lot of discussion needs to be done on this. So with that, I would, as Dr. Milind has said, we should. I will request all the speakers to stick to time so that we finish on time. And I would request Dr. Jayan Gaud to start his first talk on PSLD for lumbar canal stenosis. Dr. Jain?
Yes, sir. Thank you, sir.
So,
Thank you all, my.
should we take questions after all the this? Or should we take it after?
Sir,
what do
after
the
all
panelists
this,
feel? Take it after each talk, or after the entire all the talks? Maybe we'll take it after all the talks, because let the talks finish, then we can ask each panelist to present their view amongst all talks and then go to the this thing. Okay, Dr. Jain, please.
Yes. Thank you, sir. Thank you all moderators and panelists to give me this opportunity. So I will be talking today about percutaneous stenoscopic lumbar decompression for lumbar canal stenosis.
can you make it full screen?
Yeah. So I would like to dedicate this talk to my teachers who taught me the concept of spine and spine surgery. So we know the aging population in India as well as world is increasing, and so the age-related problems are also getting increased. So the stenosis is an important part of the spectrum of spinal degenerative diseases. So where the degeneration occurs in musculoskeletal system, it occurs in bones, ligaments, muscles, joints, and neurological structure. So there are different theories which explain the stability of the spine. But the important thing what I feel is the concept explained by Bambam Darwani. So he has told there are stabilizers in the spine, which are disc, facet, ligamentum fluum, or ligaments, and muscles and facet capsule. So anything happens in these stabilizers, they will cause symptomatas or degenerators. So osteophyte formation, disc herniation, synovitis, ligamentum fluum buckling, enlargement of the spinous process, twisting lamina. So all these things give patient pain, and whenever patient gets pain, the body try to accommodate a posture which is more pain-free. So the patient gets more list or scoliosis or kyphosis. So our aim is to treat these symptomatous, degenerators, target and make patient symptom-free. And then we can put patient to active physiotherapy or active movement therapy. So the other stabilizers get activated. So this concept of spinal stenosis is explained by Verbis in 1954. We know the main symptom is neurological claudication. Classification of lumbar canal stenosis. The main thing what we want to discuss today is a degenerative lumbar canal stenosis. So the spinal motion segment is that there are two vertebral bodies and one disc, and in that there are two facets and discovertebral joint. In the canal there is a ligamentum flavum facet capsule, and these things are in intimate contact with the nervous structure. There are a few factors which are static and dynamic, which causes the stenosis. The static factors are spinal canal, facet joint, and dynamic factor are buckling of ligamentum flavum. So this is the important diagram explained by Willis, and there are two color we can see here is the brown and here is the blue. So brown color is mainly it is the primary disc pathology. So as we know, there are columns of spine like anterior column, middle column, and posterior column. So everything starts with the anterior column. So whenever there is an end plate fracture, there is an intravertebral herniation, and it causes the inflammation of the nucleus pulposus. And from there, there is a radial tear, internal disc disruption, disc height reduction. And similarly, it affects the middle column with the capsule and with the facets, and there is a facetal degeneration, which leads to single level lateral nerve entrapment with the lateral rectus stenosis. And when one level is affected, it produces its effect on upper and lower level and causes the multiple level stenosis. So this is the normal course of this degeneration. Everybody gets annular fissure, and most of the annular fissure gets healed. But if it is not getting healed, it goes to the IDD or internal disc degeneration, and which causes this resorption. So whenever there is a collapse, there is buckling of annulus, which is more collagenous from anteriorly, ligamentum flavum from posteriorly, and facetal trophy from laterally. So all these things reduces the spinal canal and compresses the nervous structure. Uh, this overloading, the anterior column, when it is disturbed, it will cause the overloading of the facet joint, and it will cause the synovial relaxation and leads to articular fibrillation of the articular cartilage and destruction of the cartilage. There is a loose body formation which leads to capsular laxity, and which overzealous capsular laxity leads to overzealous instability. And body tries to compensate this instability with the osteophyte formation, or there is a facetal hypertrophy. So when there is a capsular laxity, there is a superior inferior subluxation of the joint. And when this tip of SAP goes into the foramen along with ligamentum flavum, it causes compromisation of this foramen. As well as whenever there is antero-posterior subluxation along with the annular incompetence, it will cause the rotation. And when there is a rotation, it will cause lateral recess compression. And when there is a superior migration, it will cause foraminal compression. So this trefoil type of the canal are more prone for the stenosis. We have to understand the ligamentum flavum anatomy to understand the stenosis. So there are two layers of ligamentum flavum. One is superficial layer, which is attached to the cranial lamina and IAP. IAP is the inferior articular process. and a deep layer is attached to the caudal lamina and below the superior articular process. And from there, it is attached below the pedicle and continues as the intertransverse ligament. So in cadaveric studies of stenosis, we can see there is an impression of ligamentum flavum buckling and causes the stenosis of traversing root, as well as when there is a collapse, there is impression of uh, exiting root also. So this is the classification of anatomical classification of lumbar canal stenosis. The central stenosis is in between facet, whatever happening in between the facet due to the disc protrusion, annulus, octavoid formation, or buckling of ligamentum flavum, we call central stenosis. The most important is the lateral canal. It is divided into three parts. One is entrance zone, mid zone, and exit zone. So entrance zone is mainly we call as a lateral recess, which is lateral to the traversing origin of the traversing inner root, and it is mainly with the help of vertical part of superior articular process. Anteriorly, there is a disc. Mid zone is behind the pars interarticularly, and exit zone is lateral to the facet joint. So again, superior articular SAP hypertrophy or disc protrusion, ligamentum flavum buckling causes the compromisation of this canal. And foraminal stenosis, mainly this compresses the exiting root. Loss of disc height, vertebral end plate osteophyte, facetal osteophyte, spondylolisthesis, and disc herniation causes foraminal stenosis. So why these symptoms arise? There are the mechanical force. This is the area of dura mater and which continues as the epineurium. So when there is a compression, there is a watershed area and there is a root vein which is getting compromised, and it causes the venous congestion. And when there is a venous congestion, there is breakdown of blood nerve barrier, and it causes the intraradicular edema and compartment-like syndrome, which gives the ectopic. And similarly, direct compression causes the again Valerian degeneration followed by ectapic, and it leads to deep muscular pain, weakness, and loss of sensation of the lower limb. So it leads to neurological intermittent claudication. So the important diagnosis is the MRI. We should get whole spine cleaning along with it, as well as get dynamic standing X-ray to rule out spondylolisthesis. So this is the classification. Uh, this is the lateral distal stenosis classification, mainly with PSF effacement, and there is crumpling of the rootlet, and foraminal stenosis is the effacement of the fat around the nerve, along the exiting nerve. So what is the treatment? The treatment is decompression. From ages, the main aim is to do decompression, what we achieve by open surgery, and that has to be achieved with the minimal invasive. That is our aim, and it helps us to reduce the collateral damage. So this is the AO spine nomenclature. Mainly, we are discussing here today the full endoscopic decompression. So what is the benefit of endoscopy? Our eye is within the canal, so we can see very clear and reduce the complication. So what are the approaches available? There are two approaches. One is transforaminal and another is interlaminar. So extraforaminal and foraminal pathology we can achieve with the transforaminal route, and mainly central, paracentral part and foraminal part. It can be achieved with the interlaminar. Even far lateral part can be achieved with the contralateral over the top surgery. So these are the generation of endoscopy. The first generation is a transforaminal surgery. It is mainly for annular fissure, non-migrated, low-migrated disc, or discitis, or far lateral disc. So it is important to do these line markings and get entry point properly to and put a needle, following needle. When once the needle is inside the disc, we can do discography, and then we can put a sleeve and do the discectomy. So this is the discectomy, what we are doing with the transforaminal surgery. After discectomy, we can see there is a pulsatile epidural space. Can we do stenosis surgery with the transforaminal route? Yes, exit canal stenosis we can achieve with the transforaminal route. So there are two ways. One is with these specialized drills. These are called as DDM drills, where we can do the ventral facetectomy. It is very difficult to do this decompression with this superior articular process and caudal lamina. So we can do mainly foraminal, extraforaminal region decompression. So this is ventral facetectomy. We can see the nervous structures as well as here we can see the exiting fat. Another way is a para-PSLD, where we dock uh, lateral to the pars interarticularis, drill the part of transverse process and superiorarticular process and free the exiting route. So the second generation endoscopy is the interlaminar endoscopy, where we are putting a small scope directly into the L5S1 canal. And sometimes we can do it for L4-5 also, but above level, there is always concordance between the distal space and interlaminar space. So it is difficult to do interlaminar surgery above this level. So it's difficult to do lateral recess stenosis with this scope. So we are retracting the nervous structure with the sleeve. Now we are doing the discectomy. The root is totally free. Here it is not necessary to remove entire ligamentum flavum. Only small rent is enough to do discectomy. So the next third generation endoscopy is a translaminar surgery, where we can use all instruments used in the interlaminar open surgery like drill or Carrison punches and do everything with this scope, including fusion surgery. So what is this stenoscope? This stenoscope is developed by Dr. Kamteklim in 2017 with outer diameter 9 to 10 millimeter, working channel 5.5 to 7 millimeter, and 10 to 15 degrees scope. Different companies are having different scopes. So what we can do with this scope? We can do discectomy, lateral recess stenosis, decompression, fusion, para-PSLD, cervical laminoforaminectomy, cervical laminectomy, dorsal decompression, and ACDS. This scope is channel scope having working channel, optics, irrigation, and illumination. The next important instrument is a drill system. There are two types of drills are available. One is low RPM, high torque drill, or another high RPM drills, which are having good torques also developed. These are very stable drills. For coagulation and dissection of the soft tissue, we need RF or plasma. So different probes are available. So these are another instruments we use for the stenoscopy. These are long instruments, annular cutter, hook, dissector, end cut burr, graspers, and important is the Carrison punch. Another instrument is a pressure pump, which is not compulsory, but it helps you to maintain the pressure between 30 to 70 millimeters of mercury and give the clear view with clearance of bony particles. So this is the OT setup for left-sided surgery. These are all high equipment based surgery, so all instruments should be checked beforehand. We prefer to use general anesthesia because it gives us hypotension and we get more clearer view. It is important to use the elevation stand so the surgeon's arm is getting relaxed. So this is the index case, L4-5 lumbar canal stenosis. So this is a normal position what we give. We always prefer to give erector spiny block. It helps post-operatively. So our aim is to target the spinolaminar junction. We put a needle, then put an incision with 11 number knife, dilate the tract with RT forceps, then put a dilator, and then sleeve. So our aim is to target this spinolaminar junction, spinofacetal junction, and tip of IAP. So this is the first view we get. We do extra spinal clearance, and this is the cranial end. This is the caudal end. Now we can see the tip of IAP laterally. Then we use drill and Carrison punches to remove the cranial lamina till the ligamentum flavum is getting detached. So this is the drill, and followed by Carrison punches we use after thinning the cranial lamina and ligamentum flavum is getting detached. So the next important thing is identification of caudal lamina. So we trace caudal lamina from the tip of IAP, from the horizontal part of SAP, and which continues as the caudal lamina. So we can see caudal lamina here, and we can define the margins of caudal lamina with the help of curate. The next important thing is going contralaterally. To go contralaterally, we have to drill the base of the spinous process. So we start from distal to proximal, and we try to drill base of the spinous process and try to keep the inner layer of ligamentum flavum intact. So it gives us always protection to protect the nervous structures below. So this base of the spinous process continues as a cranial contralateral cranial lamina and contralateral IAP. So once we get these things, we start drilling and create a space. So we can use these wooded cutting burrs, or we can use direct diamond burrs without any protection. Whenever there is a ligamentum flavum intact, it is not worrisome to that we are injuring any structure. It is always protective. So this is the contralateral cranial lamina, and which continues as a contralateral IAP. So the next step is identification and detachment of ligamentum flavum from contralateral caudal lamina. So once we detach ligamentum flavum from all the sides, it is easy to remove the ligamentum flavum from lateral reaches. So first we do ligamentum flavectomy from ipsilateral side, and last part, which is remained of ligamentum flavum, we remove to decompress the traversing root. Similarly, we remove the ligamentum flavum from contralateral lateral reaches. So this is the contralateral root. So whenever there is a discal pathology, we can do discectomy with retraction of traversing root, like open surgery, with annular cutter and graspers. Followed by this, we do the RF annuloplasty, which helps to prevent the postoperative back pain by ablation of spinovertebral nerve. So we always put drain for 24 hours. This is the postoperative MRI of the patient. What complications can be associated with this surgery? So the incomplete decompression, so we have to do the first bony work. There are chances of dural injury, but which are like reported less than 4%. But there are small dural injuries which can be treated easily with the wound clot, or large dural injuries can be treated with the Duragen, Taquashil, or glue. It is important to see if any rootlets is getting entangled or strangulated. Whenever there is if rootlet is getting entangled, we have to increase the rent and then use all these things. Very large dural injuries, when it is not getting treated with all these things, we have to open the set. Then transient dysesthesia, it is reported less than 3% of the patients. Hematoma, we have to reduce BP below 30 millimeters of mercury. We have to reduce pressure below the 30 millimeters of mercury, and then check hemostasis. Put drain for 24 hours. Remnant or recurrent disc can be treated with removing all the sequestered or loose fragments, followed by RF annuloplasties. And pressure injury can be avoided by maintaining pressure 30 to 60 millimeters of mercury and gentle manipulation of nervous structure. So our experience of 75 cases, we had done multiple level cases with a single incision. So average time for single level is around 1 hour to 1.5 hours. So this is
endoscopic spine, which came in about 90s, and so many people are doing it since that time. Now we are in the generation of endoscopic decompression and foraminotomy, and now many surgeons are doing lumbar fusion as well. This is exactly how your progress should also be if you're an aspiring endoscopic surgeon. To start with discectomies, progress on to interlaminar discectomies, then go for decompression, stenosis, and then for fusion or advanced surgeries. So first generation is the transforaminal approaches. Like just Dr. Jayant has just shown a video, so I'll just touch upon the video over here. Like I said, the marking is very, very important. I used to do this a lot of surgeries, transforaminal approach. I used to use methylene blue to stain the disc material, and then we know how much and which disc is to be removed. The dark blue color is a degenerated disc. Light blue color is not necessarily a degenerated disc. You can see the annulus and the rent over here. You can see the extent of your discectomy on a C-arm. It's a slightly indirect method of decompression, unless you are doing a half and half technique or an outside in technique, in which you can do a nice decompression under vision. I'm just running this video through for the want of time. The limitations of transforaminal surgery were neural and bony. Like you can see over here, there is nerve root that are traversing over here. There is a nerve root that is passing over here, the thecal sac and the traversing nerve root. Plus, there are a lot of bony challenges, a very small foramen to fix a large dilator and a working channel and endoscope through this small foramen, which is very typical in Indian patients, might be detrimental and cause neural injury over here. So second generation was developed, in which you can see that this is a standard lumbar surgery, what we have been trained to do for years together, and results have been fantastic. But there are limitations that patients may develop chronic back pain, they may develop listhesis if there is a slightly overcutting of the lamina. And we all know the limitations over here. Dr. P.S. Ramani, my teacher and my guide, taught us this concept of IDSS, which we've been using for microlumbar discectomy since years together. The same principle of decompression, that is the red square that is shown over here, the attachment of the ligamentum flavum, that if you remove any technique, the result is going to be almost similar. I'll touch upon the topic what I'm saying. So from open decompression, we have come to endoscopic decompression and interlaminar decompression. From laminectomy, we have come to laminotomy. And same thing can be achieved by unilateral muscle dissection, muscle dilatation actually. And you can see these are the standard steps that Dr. God also has shown. You reach the spinolaminar junction, you start drilling, you decompress the same side, then you move the base of spinous to the base of spinous process, go on the contralateral side and achieve an adequate decompression on both sides from unilateral approach. So Destando technique also does the same thing. There's a conical slot for suction. You can see there's a slot for suction. There is a slot for the scope. There is a nerve retractor, and there is a 8 mm working channel. And there's a 12 degrees offset between the instrument and the endoscopy channel, which allows you to visualize nicely. This is one of the case of a large gibbous formation over here, and patient had a tethered cord. So my orthopedic colleagues requested me to do a minimal invasive surgery so that they doesn't come in their surgical way when they are going to do for a spine fixation. And we had done the Destando endospine system we had used to do detethering of the cord. This is one of the only reported case in India. You can see the nice, beautiful blue color of the phylum. We used neuromonitoring to confirm that what we are cutting is a phylum and nothing else. Standard coagulation and cutting was done, and repair of the dura with 3 mm titanium anasto clips auto loading was done. Very good technique. Destando surgery is a very, very good technique. Patient can be mobilized very fast. There is a post-op scan showing a free cord. EasyGo system is another similar technique by which you can, there's not much difference, just an angled endoscope is put in a tubular surgery. Outcomes of tubular surgery with microscope, loops, or endoscope are essentially the same, which is why we call it micro endoscopic discectomy or decompression. Decompression discectomy can be done beautifully. This is a 2-level, this is single level, and the results are very, very good. Now that we come to third generation, where we are doing fully endoscopic underwater decompression for spinal stenosis. Earlier, stenosis used to be a contraindication for doing disc surgery. This, again, the scope Dr. Gaud has shown. This is the same system that I use by Dr. Kanktek-Lim. Very few instruments are required for this surgery. The basic are the punches, tactile hook, just a dissector, dilator, working channel, and an endoscope. 2 or 3 graspers and annulus cutter are enough. This is how the scope looks. You have a 5.5 mm working channel in an 8 mm endoscope. This is the endoscope itself over here, the working channels, the irrigation and the suction channel. Preparation is again very simple. You Fix the patient, you have to use a waterproof drape over here so that the water is, you can manage the water irrigation system very well. You put the dilator, slide in the working channel, prepare and connect the endoscope, check it, check your shoot on the laterals and APC arm. And this is a simple case of L5 S1 disc herniation. Patient came with a very classic posturing. He was on conservative treatment for 2.5 months when he decided to go for physiotherapy at a very famous physiotherapy chain. And he came with a acute posturing that he could not move, lift, breathe, anything. So we had to take him for surgery. And this was the discectomy. You can see that the entire, you can see on the image over here that the working channel has been used to retract the thecal sac and the traversing nerve root, exposing only the disc material over here. Disc pieces have been removed, annuloplasty with radiofrequency done. The working channel is being rotated to show the free nerve root. And like Dr. Gaud said, we don't need to do a very large ligamental opening for a pure discectomy case. There's hardly any bleeding. This entire surgery is being done without any irrigation system. Only gravity assisted irrigation is being used. Water kept about 90 centimeters above the patient's surgical field is enough to give a very, very good vision. And you can see the pink healthy muscle, and from that we have removed the scope. The patient is able to walk so freely and being sent home the same day at 6 o'clock for discharge after the morning surgery. We do the surgery under local anesthesia. Unless surgery is more than 2 levels, only then we put the surgery under GA, because the prolonged time for patient to sleep in that position might be a bit difficult. This is a case of L4-L5 discectomy and decompression. You can see that we are drilling the area over here. This is exactly what Dr. Gaud was speaking about, a high torque, low RPM, 5000 RPM drill, which is used to drill out the overlying lamina and just open up the ligamentum. After the drilling is done, you use a small 3 millimeter or 2 millimeter kerosene punch. You have thinned out the bone, you remove it, expose the ligamentum. You can see the ligamental upper attachment over here. The ligamental removal has been started. You're on the contralateral side, removing you're across the midline and removing the tight ligamentum, the tight spinal canal on the opposite side. Use a radiofrequency probe, which is very, very safe to use on neural tissue as well at a very low current setting. The temperature that it produces is about 47 to 51 degrees Celsius. Pretty safe as compared to any bipolar coagulation, which can cause up to 90 degrees of heat formation. Patient also has a disc, as you have noticed on the MRI on the side. And we're using it, the dissector, to tease out the nerve root, the disc. Use an internal retractor. And under vision, you have to rotate your scope to see both the ends of your disc forceps, and you can remove the disc very nicely. At the end of the surgery, you see this, I'm palpating the pedicle on ipsilateral side, and we have done an adequate decompression, complete ligamental removal of and freeing both the nerve roots on each side is done. The vision that you can see in a tubular surgery and the vision that you can see on a endoscopic surgery, that's the big difference over here. The drill makes all the difference. The kerosene punch, you are so close to the drilling and the punches that your vision and control is significantly higher than with loupes or microscope or even ECG system. Even cervical spine surgery, you can see that an entire decompression has been done. Without any risk, because you are using a drill, not under very heavy irrigation. The risk of complication is very, very less. This is a typical learning curve. So a few topics I'm touching upon that Dr. Gowda has not covered over here. This is a typical learning curve of endoscopic spine surgery by interlaminar technique. 24. That is a key number. You start, your time for surgery is very, very high, and then it starts dropping significantly. At this point, typically 40, 50 cases, you start taking more complex cases, and then your time again increases. And then there is a significant drop in the amount of time that you're taking and the complications. And this is a cumulative complication scale, and that will tell us how much time you're taking for a surgery, the blood loss, the outcomes are everything. Then they go to about at 90 cases, 80, 95 cases, you reach a stabilizing endpoint. Few guide points, key points over here. Always invest very well in the instruments. That is investing in yourself. Buy the instrument yourself and don't let the hospital buy it. Prefer the best optics in the beginning. When you drive a car, your parents have taught you to take a second-hand car, try a second-hand car, and then I'll buy you a new car. No, that does not work so for your instrumentation. Buy the best endoscopes possible, because your optics are going to tell you, if you can see well, you can operate well. If you operate well, your outcomes are going to be good, and you're sure of your technique and you will progress in that. Your dilator, endoscope, and working channel, they are married to each other because the size difference is 0.5 millimeter. So you can have to have all three of one single company. The instruments, you have to always know your instrument very, very well, so that you can buy the other instruments based on this. If you have a 3.5 millimeter working channel, you cannot buy a 5 millimeter punch, for example. Instruments, again, try to buy the set yourself. You can replace instruments with the local vendors. They are really good. They work a lot. And the outside ones are really very expensive, the imported ones. RF and drill system are the main cost limiting factor over here. I'm using fully Indian-made companies, and they are really, really affordable. Almost 3 years, I didn't have any drill system. I used to use with a punch. And then you can progress on to getting a drill and doing advanced cases like stenoscopy and like decompression and fusion and other surgeries. Which patient to choose? Always start with lower lumbar levels, left side pathology, unilateral symptoms, single level disc, a lateral disc herniation, typically L5S1. You should start with that, a left L5S1. I waited for the first, when I bought the instruments, did only 6 cases in 1 year. That was the selection criteria. Single level, single-sided discectomy, then go for decompression. Then you can go for 2-level decompression, then multi-level decompression, redo cases and posterior cervical decompression, and then you can go to endofusion. There is a steep learning curve as you progress from one level to another. All cases initially should be done under GA. Then you can, because you might take a long time. A first case took 3 hours. Now it is about 25 minutes per level. But initially, patient cannot sleep prone for 3 hours. You are panicking, patient is panicking, doesn't help anyone. Incision, initially, you should take a vertical pyramidal incision, which can be converted to an open or tubular very, very easily. You don't need to have, you start with a transverse, which is more beautiful and along the Langer's lines. But then if you need to convert to an open or tubular, then you are in real trouble. You have a T-shape or a crossed incision. So you know the advantages of endoscopic spine. It can be an OPD procedure, can be done under local conscious sedation. It is very good for patients who are unable to tolerate open surgery or general anesthesia. The learning curve is very, very individual. You have to progress on your own. After 200 cases, I did my first fusion case, and now I've done a lot of fusion cases. But initially, you should not try for fusion just because everyone else is doing it. You follow your own learning curve, and then you should progress to the advances and the next step. Radio frequency coagulation is a real game changer, which is very, very important for you to have. Underwater coagulation is very easy, low heat production, and that helps you with the patient controlling the bleeding and everything. So RF coagulation is very important. Irrigation, I use underwater or irrigation system also can be used, pump can be used, and conscious sedation are the main advantages of fully endoscopic system. So thank you so much, and I'll be happy to answer any queries if you have any.
Thank you, Sumit. I think that was quite informative. We will take questions at the end. After the panelists give their opinion, then I will come back to you for the questions. So in the meanwhile, we asked Dr. Rahul Ahluwalia to present his
Yeah, Rahul,
talk
can you
on
share your slides?
can you use him? Unilateral biportal endoscopy in lumbar canal stenosis.
Hello, am I audible?
Yes, you are audible. Can you share your screen?
Yeah, just 1 second, sir. Just 1 second.
You can share screen, Dr. Rahul.
Just 1 second, sir.
So in the meanwhile, I think, Sumit, there is a question. What are the rates of infection in saline irrigation system?
Sir,
And
I would
does
like
RF
to,
infusion has any side effects?
yeah,
So
sir,
can
very
you
good
give an
question. I would
answer?
like to quote our Dr. Ketan Deshpande for this, that
Yeah.
solution to pollution is dilution.
Okay.
In my more than 400 cases of endoscopic spine, I have not seen touch wood a single case of infection, because whatever infection is there is getting washed out due to the irrigation. You are following the
Okay.
very basic techniques of no touching, because when you're changing the typical irrigation, people have a habit of touching the cannula and then they insert it inside. It's going to cause infection. If basic things you have taken care of, we have not seen a single case of infection in endoscopic spine surgery.
Okay. And does your RF coagulation has any side effects of head
Yeah.
injury? That you
Yeah.
have answered, I think. Yeah. Okay. Thank you, Sumit.
Thank you.
Dr. Rahul, can you? Dr. Rahul is Ahluwalia is a consultant neurosurgeon at Raipur, and he's the chairman of the Radical Academy of Spine Endoscopy. Rahul, you can start your presentation, please.
I hope you can see the
Yes, we
screen.
can see. Yes, we can see your screen. You are audible.
Basically, Sumit sir has probably spoken regarding the PSLD, or what you call as the interlaminar monoportal endoscopy. I will be talking about the biportal endoscopy, which basically decouples the scope and the working portal. So, lumbar canal stenosis is a very common degenerative disease that we come across, especially because of the flavum hypertrophy. And as the age, the life expectancy is increasing, we are getting more and more patients with the same problem. They primarily present to us with neurogenic claudication, and it is essentially a disease of the old age where concurrent morbidities like diabetes, hypertension, coronary artery disease, they are coexistent. So they pose a lot of challenges for the anesthesia as well as for the surgical outcomes. So why choose UB? Like I personally have seen, I've experienced monoportal as well as biportal endoscopies both. And I've realized that UB is actually the pinnacle for an ultra minimally invasive approach to any level in the spine. It gives a panoramic view with pristine clarity and magnification. There are zero blind spots. I will discuss what is a blind spot later on, and the ease of instrument maneuverability because of the ergonomics of the technique, and there is no multifidus injury at all, something that we experience with an open or the tubular retractor system that has been conventionally used. Now, if we talk about biportal endoscopy, the premise is the creation of a Son's space. Now, what is Son's space? I'll show it in the images later. the multifidus muscle, it attaches on the spinous process, but it rests upon the lamina. So there is a potential space that we have, and this is the space that we actually make use of. There has to be a provision of continuous water cross flow. So since there are two ports, there's an inflow from the scopic portal, and there has to be a good outflow from the working portal. The magnified view, which is crystal clear, is provided by a scope. And then the underwater electrosurgical units, which I'm pretty sure Sumit sir has discussed previously, they help us take care of some latent tissue which might come across in the field. If you see this MRI image, the two portions of multifidus muscle have been marked very clearly, describing their sizes. If you look at the multifidus muscle, medial to the multifidus muscle and between the lateral to the spinous process, there's a T2 hyperintense zone. This zone is basically soft tissue like the what you call as the fat, the areolar, loose areolar tissue. So this loose areolar tissue is the premise for the Swan space. This is a Swan space that needs to be developed in biportal endoscopy. This is an image that I've taken from Dr. Ashwin Khandia. He's a orthopedic spine surgeon. He does biportal endoscopy. So if you, this is the basic concept of biportal endoscopy. You have the scope and the working portals triangulated at the spinal laminar junction, and the Sons space is developed, and you can see the water basically elevates the multifidus muscle, providing a working space. Now, this working space is not more than 5 to 6 millimeters in the ventrodorsal direction, but that is more than sufficient for us to work inside. Now, what is triangulation? Triangulation is the ability to interchange 2D and 3D views inside our brain. And depending upon the pathology to be dealt with, skin markings change. I mean to say, if you're dealing with stenosis, the skin markings are different. If you're dealing with a disc, whether it's extruded or migrated, the skin markings slightly change. In fusions, the skin markings are again different. Now, that's part of a learning curve that we actually have to grow upon. This is the basic skin marking for a patient where a stenosis has to be taken care of. What you can see here is that I have marked the midline, then I've marked the disc space, then I've marked the medial pedicle line, that is the MEPL. Two pedicles have been marked, and a triangulation has been done at the level of the spinolaminar junction. This is a case where two-level markings have been done for two-level stenosis. Now, depending upon the experience of the surgeon, one can go for such a kind of marking where, the working portal and the endoscopic portals change. And with experience, one can start doing two-level decompressions with single-level markings. Now, that is uh, something that depends upon surgeon to surgeon. I still prefer to change my portals. This is the initial view that we tend to achieve once you've created the Sons space. This is the initial view you tend to get. You've landed at the spinal laminar junction. At 12 o'clock, you have the spinous process. At 9 o'clock is the cranial lamina. At 3 o'clock is the plasma RF band that you can see. And at 6 o'clock is the extension of the lamina laterally. Now, this is a video I would like to demonstrate regarding development of the spinolaminar junction and the creation of the complete Sons space that you can see over here. This is the RF band where we are developing the space around the spinous process and the spinolaminar junction. the priority is to delineate tissue right from the spinal ulnar junction medially up to the facet complex lateral. This is the facet complex that you can see. And this is the basic premise that defines biportal endoscopy. Any lateral movement, and you'll reach the SAP at that level, and that delineation is usually reserved for fusion surgeries. Now, once the basic tissue dissection has been done and you've achieved delineation of tissues, we use a small Penfield or a dissector, and we delineate the plane between the lamina and the interlaminar tissue so that the drilling process can be started. In this video, you can see I start drilling with a cylindrical cutting burr. That is my choice. You can also start with a rosette cutting or even a diamond burr. So initial cortical bone, I prefer to drill with a cylindrical 3 mm cutting burr. And once that process is completed, I usually shift to a diamond burr when it comes to the cancellous bone. The whole process depends upon a combination of drilling and ablation of tissues with a good RF machine. The water ensures that you get a good view of the tissues, and as good as the cross flow, the better will be your view. Once we have drilled across the cortical bone, we start drilling the cancellous bone and also try and go across the base of the spinous process. Here you can see I'm drilling across the base of the spinous process. Intermittently, I shift my drilling between the facet. This is the drilling of the IAP, trying to shave off the base of the IAP. All of this drilling is being done with the phlegm being kept intact. And this is how you have to change between your RF and drill. That is the working instrument predominant in biportal endoscopy is the RF and the drilling part. Any bleed that comes from the cancellous bone can be dealt with the drill, or even a bone wax can be applied, or the RF can be used to take care of the cancellous bone bleed. Once the drilling has been completed, we can go across the removing of the phlegm with our standard Carrison punches and hooks. This is a patient I did recently. He had a very calcified phlegm and a very tight lateral recess stenosis at L4, L5. Was trying to remove the phlegm with the Carrison punch, but was not very successful. So I had to lift the phlegm up with a hook and dissected off the dura. Now, the advantage of doing a wet medium or a saline medium endoscopy is that water helps to dissect away the tissue very well. You get a very good cleavage plane between the dura and the phlegm. You can see the Hoffman's ligaments, that is the posterior epidural ligaments that are attached between the dura and the phlegm. You can take them down individually, and that basically helps to prevent dural tears. Now, dural tears are very demanding when it comes to water-based endoscopy, because depending upon the size and the whether the noodles are herniating out or not, the management completely changes. So this is the first time I'm introducing a ronger inside to take care of the phlegm that has been separated away. Now, at times, what happens is when we remove such a phlegm, you do tend to have the epidural fat and vessels, they start to bleed. So, obviously, you have a good RF system, you can take care of them. Now, once this is a video showing where I am showing you the complete decompression. This is the left-sided traversing route, and the disc space can be seen over here. It's a completely decompressed cranial to caudal thecal sac at L4, L5. That's the contralateral side. You can see the size of the scar now. Now, if we come to this image on the right side that shows the size of the scar, now this is one of the cases from my initial practices. Now I prefer to use a 5 millimeter tube for the working portal if I'm not doing a fusion. If I'm doing a fusion, I still prefer a 1 centimeter portal to be made, and the portals are little lateral. Now, this is the video that I took in a case of fusion for lateral or for a grade 1 listhesis. There's a complete decompression. You can see the cage over here. So basically, we depend upon the concept of four root decompression when it comes to biportal endoscopy. One must be able to decompress the bilateral traversing and bilateral exiting routes in a case of lumbar canal stenosis, because if the exiting routes are not decompressed properly, the patients tend to come back. This is the size of the bony work you can see in a patient of lumbar canal stenosis. It's a very small interlaminar window that is made. Also, I would like to show the size of bony work that we do in a case of fusion. And in low grade listhesis, I tend to put in only two screws on the side of my axis, whether it's the left or the right side. Thank you.
Thank you, Rahul, for that wonderful lecture on UBE. I think we have finished all our lectures, and I would request we have four panelists here, and I would request our esteemed panelists to give their opinion on all the three topics, and Dr. Datta Prasad Katikar and Dr. Anil Patil, Dr. Sandeep Viratwar, and Dr. Vivek Bonde. So can I request Dr. Katikar to give his
Yeah.
comments on the lecture? Yeah.
Excuse me, sir. Just one announcement. We may get some trouble in 1 minute. Then we
Okay.
may have to relog in again.
Okay, fine. So quick comments from our esteemed panelists so that we can.
Yeah, sure.
Yeah.
Thank you for all the speakers for giving a very crisp and informative lectures. I think because of short of time, we might have many questions being asked and asked. So I think we should give maximum time for that, Dr. Buzumda.
Yeah. I think you can
Yeah,
just.
because I think no, but that is all. Dr. Anil Patil wants to contribute anything?
Anil Patil,
10-15.
Anil, is he there? Or we,
Dr. Vivek Bonde.
Vivek Bonde?
Yeah,
Yes, Vivek?
everything is covered by all these three speakers. Now there are different things in different in total endoscopy the problems are different, and in UB the problems are different. Probably this everything will be covered in questions. Otherwise, we can discuss with them.
Sandeep?
Dr. Sandeep.
Yes, sir. Yeah, thank you. All the speakers have been fantastic, sir,
Yeah.
and they have covered everything pertaining to this topic. I have a question to Sumit Pawar. Sumit, now you look like a very matured endoscopic spine surgeon, and I have this question. Uh, there are evolving systems in the spinal endoscopy from uniportal to biportal, So I just want your opinion.
I, I think
Sumit is
every
here. Sumit is
Sumit is
here.
here.
Yeah.
Sumit.
Yes, sir. Sorry, sir. I listened to half of your question that multiple techniques are developing.
Yeah, I just want to know which system you're using and your opinion on unilateral biportal
Yes,
endoscopy
sir.
system.
It's a very good question, sir, and the most difficult question to answer. Because I started doing transforaminal, but in my opinion, I have hardly been able to do any case transforaminally because patients which are suitable for transforaminal in India, we're able to very happily conserve them. They usually improve with purely conservative treatment, even a root block at the most, but they improve. All Indian patients come at a stage when they have everything. The facets are too much hypertrophied. Ligamentum is always buckled. It's always hypertrophied, and I have not been able to do justice with transfrontal. So now my entire focus is on interlaminar technique only. Outcome wise, there is almost no difference in monoportal and biportal technique. I have started doing biportal technique on insistence from Dr. Rahul himself. And it is a very good technique. The vision is slightly better than monoportal because of the size of the endoscope. He's using a standard 4 by 18 millimeter endoscope, which is a your routine sinoscope. The cost of equipment is extremely low. So you can set up a UB, you can start doing a UB case even day after tomorrow in your own hospital because you have almost every single instrument available with you. I found that I need a lot more irrigation. When we are doing a monoportal surgery, we are doing under pressure. So with gravity itself, my pressure was built up quite adequately for me to do a surgery. I can finish in we use a 3 liter saline bottle to do the surgery. In 1.5 to 2 bottles, my surgery gets done. For UB, I found the irrigation to be much, much, much more higher than what I was using for interlaminar. That is the only reason why I stopped doing it. Initially, when you start doing the triangulation, the vision is almost significantly, you're not able to see the instrument channel, the instrument when you're doing the endoscope. That slight blind effect is there for about half a minute or a minute. Apart from that, I think Dr. Rahul has said very well that maybe for fusion cases, UB might have an upper hand as compared to monoportal surgery. When I'm doing monoportal fusion, I am essentially doing a biportal fusion because I cannot put the cage through my monoportal channel. It's 8 millimeter scope. Working channel is 5.5. So I'm shifting on the side and I'm pushing the cage from blindly from one side till I see the cage. I'm not sure. So that's essentially a biportal technique only. But for decompression, multi-level, 4-level decompression I've done, and time was just less than 2.5 hours. So I'm very happy with monoportal for everything else.
Good.
Yeah, another short quick question, sir.
Yeah, Sumit, there is one question for you. Does Dr. Sagar Gowli from Sion Hospital? He is mentioning whether your irrigation can cause any cerebral complications.
Yes, yes, yes. Very significant complications can occur if you are using the pressure irrigation under high pressure. If you is irrigation pump, it can also lead to blindness. It can lead to seizures and something you just can't explain in a routine spine surgery. So you have to be really careful how much pressure you're using. We are using almost only gravity assisted irrigation, which almost will never have a problem of seizures or blindness because the pressure is just based on gravity. You're not using a pump to force it. You must have seen the clarity of my video is not very good because of the bleeding. You see, it's like putting a drop of ink in water. It's going to turn blue. Same way, a small drop of blood is going to cause redness in the field. You can see everything, you can do everything. There's no need for doing an irrigation pump just to show nice videos, is what my opinion is.
So
This blindness is not mentioned anywhere, I think, because of irrigation. Is it because of position, which is a prone position?
No, sir. It is published. It is standard. People, I think, who are doing very high center and very high number, they have published it that it can cause blindness as well.
What is the mechanism?
So I think it's. I'm not very sure of the mechanism of the injury. Could be due to the high pressure that you're causing in the against ICP. Possibly, it could cause it. Neck pain, back pain, is very common under local.
There is a question for
I'd
Jayant
like to
as well
interrupt
as
here, sir.
Sumit.
I'd like to interrupt here, sir, but retroretinal hemorrhages are a very known and documented complications in water-based spine surgeries, especially because of the pressure that is reflected through the dura. And such a complication is very well known across the group of endoscopic spine surgeons, be it an interlaminar endoscopy or be it a biportal endoscopy. Even one of my colleagues has seen seizures in a transforaminal endoscopy because of high pressure. So the pressure that is reflected.
Reportedly, that was higher in transforaminal than interlaminar or stenoscopic. Reportedly.
Higher in transforaminal surgery, sir.
Yeah, that's what I heard. Fortunately, never seen.
So Rahul, there is one question for you that whether UB is useful for right-sided surgeons. Is it the right side which is to be used?
Approaching a right-sided pathology by, see, I'm a right-handed surgeon. So, sorry, I'm a right-handed surgeon. And I quite often do a right-handed surgery. I've even done fusions on the right side, even redo surgeries from the right side I've approached. So what I do is I maintain the same concept as with the left side. That is, the scopic portal remains cranial and the working portal remains caudal. To achieve that, I go on the right side of the patient, I develop my portals, come back again on the left side, and I do the surgery as a standard left-sided surgery. So nothing changes for me.
Then do you need to tilt the table towards you or you work in the neutral
No,
table position?
I haven't tilted the table so far. What I do is, yes, of course, for the right-sided surgeries, I tend to keep the patient a little closer to me.
Yeah, but when you are trying to go over the top, it's like you are standing on one side and then from opposite side you are trying to come below the spinous process on your own side. Then the
Yes,
tilt will
yes,
be quite a bit.
yes. It is a little challenging when you imagine it, but once you start doing it, it is a piece of cake.
Okay, we'll take your word for that.
Because I
Any
actually use a 30-degree scope. I have I have always done UB with a 30-degree scope. My 0-degree scope is a backup in case I lose my 30-degree mid surgery because of the drill or something. So with a 30-degree scope, the view is very panoramic and it is very easy to, just drill away little amount of spinous process and you can see the contour outside completely.
any other
So,
question from panelists?
Yeah.
I have
So
one comment
Sumit,
on the same. Sorry,
Yeah.
I
Yes.
have comment on the same question, though I don't have that much experience as Dr. Rahul, but they have explained the four methods for this right-handed surgeon for the right-handed pathology. When you are standing on the left side, you can do over the top, or you can do over the midline from the left side.
Yes.
If you are standing
Yes.
on the right side, either your camera is in the endoscope is in the right hand and instrument on the left hand, or you can do the reverse. Your endoscope is on the left side and your working instrument in the right side. All four method can be done. So unless and until people start doing on right side, they have this question. But once they start doing, they can do it very well.
yeah,
There
this
there is a
this
very
question is for
pressing point.
Sumit as well as Jayan.
Yeah.
If you have to abandon the procedure because of say anything bleeding or dural this thing, what is your approach? How do you go? Do you go for like how do you ascend to the salvage?
Sir, I'll give my experience about this. That I've had three cases of dural tear, in which and total three cases I've converted from fully endoscopic to some other technique. All three I've converted to tubular surgery only. I always have my tubular surgery set as a backup every single endoscopic case. And I have done one case of dural leak. I saw a big rent and I saw all the nerve roots were popping out. So I had no option but to abandon and I had to convert to a tubular. And I always do primary dural closure. All my friends, they suggest that they can use Tacosil, Duragen or anything else for uh, treating the dural tear. I've always believed in watertight closure. And through tubular, I have done a watertight closure of the dura.
Okay. And Dr.
I would
Jayan?
like to mention one case. Like initial days, I got a big dural rent, and I continued the surgery. And problem is that post-operatively, patient was not able to get up for at least 1.5 hours. I was very tensed. She was having severe headache. She was not able to talk anything, and for 2 hours it was unimaginable. So I think I am agree with Dr. Sumit sir that we have to whenever there is a big dural rent, we have to consider MIS tubular system.
Another thing is the complication that we're mentioning in the as a raised intracranial pressure. Are because of some trivial cut on the dura which went undetected, and that's why it caused the increase in the ICP.
Sir, possibly. Sorry, Jen, please continue. Sorry.
No problem. Sir, actually, what I think, I have not got any other patient other than this patient that is showing any nuchal headache or any like severe headache, which is any other complaints like this. But only thing I can say that we have to continuously check our irrigation port, because that irrigation port is the most important, irrigation and draining port. So draining port, if it is getting blocked with any bone particles, it is chance that there is increased pressure inside the canal. So for that, sometimes routinely I don't use pressure pump, but sometimes whenever there is like bleeding, I cannot see anything, then I connect to the pressure pump, and this pressure pump helps me because it is having a negative feedback mechanism. So if the pressure is getting built up, whatever set pressure, then it automatically cut off the pressure.
I think Dr. Rohidas wants to ask a question. Dr. Rohidas is here. Dr. Rohidas is here. He wanted to ask some question, but I don't see whether he is logged in. So,
हॅलो
Rohidas, yes.
अरे
You-
चांगली अरे बरी आठवण काढली आमची तुम्ही.
अरे तुमचे मेसेज बघितला मी म्हणून आठवण काढली.
अरे म्हणून विचारतोय. फक्त
बोला,
एकच
बोला.
क्वेश्चन आहे.
येस येस. कोणाला ऐकू?
सगळ्यांनी उत्तर द्यावं. सगळ्यांनी उत्तर द्यावं.
सर कॅमेरा ऑन करा ना तुमचा चेहरा. कॅमेरा ऑन करा, तुमचा चेहरा पण
चेहरा
दिसेल.
बघून काय करणार राजा?
MCNS प्रेसिडेंट चेहरा पाहिजे.
मूड कळतो मूड.
अरे या वेबिनार कमिटीला प्रेसिडेंटला इन्व्हाइट करायचा वेळ सुद्धा नाही. आता काय करणार सांग?
आता मला कळलं. ओके ओके ओके.
प्रश्न फक्त एवढाच आहे की फॉर अ लंबर स्पाइन सर्जरी, सपोज देर इज अ फ्लुइड टेक्निक. सुमित, दिस इज फॉर यू ऑल्सो.
Yes, sir.
Suppose there is a dural puncture which is unnoticed and there is a CNS complication which is reported. Convulsions, hemiplegia, hemiparesis, everything is reported. How to defend ourselves in the medico-legal case if it happens? Because for a simple surgery like a nerve root surgery, if this complication occurs, the technique is culprit or the surgeon is culprit?
So it's a fantastic question that you have asked over here.
And unnecessary, we are सीधा घास खाने के बजाय पीछे से खा रहे हैं और नीचे गिर रहा है. One complication in a lifetime and it goes into the court of law, we will not be able to defend ourselves.
So we have complication like blindness in every single standard spine surgery. It cannot be explained to any layman how it is happening, but it does happen. It has happened.
But this happens convulsions, convulsions, hemiparesis, hemiplegia.
So we have published one case of a pneumocephalus post lumbar spine surgery due to durotomy, which I think we have never even heard of. Anything can happen in any single case.
No, listen. But is it possible to defend ourselves for such complications which is not related to the pathology, but which is related to the technique?
So if
because of this complication only, the anterior disc replacement surgery is nobody is doing it, or it is not done routinely because of the vessels. There are vascular surgeon has to be on call at that time, and there is a chance of death. Correct?
Are these complications reported in literature?
Yes.
then it
Yes.
will be easier for the relatives to be counseled before surgery only.
Exactly. Counseling is
but
everything. Counseling, and if
but
you're able to explain every single complication of including by
but
considering,
honestly tell me, do you inform all these complications?
sir,
I think
every
it should
single
be informed.
complication and
No,
they have
CNS
never happened.
complications are not informed.
Yeah, but they should be
Sir,
informed. There is no
how
question
many?
Not
about that.
Tell me
informed.
one thing, sir, Dr. Rohidas. How many?
Hmm?
First of all, please committee start inviting sir for this.
नहीं अभी छोड़ दो, अभी वो भूल से गई, वो हाउस से नहीं
So
आई,
it was
भूल से
never
गई है.
earlier done in 3 years. It was never done in 3 years. The webinar was going on every month, but I think the message was always
I think I will
given
अरे
on the WhatsApp.
एंडोस्कोपिक सर्जरी शुरू की गाली खा के हमने, हाँ, ये
yes.
सीनियर्स ने भी हमको गाली दी है.
So you
I
are
think
भी
Dr.
याद
pioneer
नहीं
that
आता
everybody
है.
accept.
Wait a minute, Sarang. I think Dr. Rohidas, your point is well taken, but you know,
No.
the
The
circumstances
problem
sometimes
is that we don't inform the complications.
yes.
That is
I
the
think
problem.
we should. There is no question about it.
So believe
And
me, every
yeah,
single patient, at least in my practice, he is informed about the blindness. He is informed about inadequate decompression. Consent is
No,
taken
that is
as
inadequate
well as
decompression.
open lumbar decompression.
no, but
Sumit,
I think
We
inadequate
can talk
decompression
about
is.
routine complications.
I think I
We
will
can
add
talk
that.
about routine
Okay.
complications, standard complications that are
Yeah, but
routinely documented. But
yeah,
one-off cases like there has been a case report of subdural hematoma after
yeah.
Yes.
spine endoscopy. That's a
Sup-
one-off case. These are case
my
reports.
I'm not against any technique. Suppose this patient goes into the court of law.
So then you have to defend us.
Yes,
No.
I think this point.
No
No,
no one will defend you,
but
because
this
this is
goes back.
related. This is related to the technique, not the surgeon.
How much is
You
the
are using
incidence for that matter?
But I think Dr. Ravidas, I think
Of
we
these
have
there are
complications.
there are
we have to take
incidences.
back
There are
our
incidences.
yeah, but we have
Now
to
one
take
of
that right.
one of my friend Nicola Piu, Sumit, you know him. He was in.
Yeah.
His patient is hemiparetic since last 1 year.
He has to report that case.
Here he is
Yes.
reporting.
Public.
He is going to
But
report.
sir,
Yeah.
how is
I
it
think this
explained?
happens with any new technique. As you proceed along and the experience is generated, I think more reports will come, and then we will be in a better position to counsel patient. But I think death has to be death or disability has to be told to every patient of neurospine. I think we have to
Yes.
tell 1% chance of death.
There is increased risk of infection also.
Yes, so we are. I think
Nobody
that
reports
should be covered.
infection because this is a fluid medium.
Yeah.
So because
And one more
actually
thing.
infection is very low. I have not experienced infection in the last 2000 surgeries.
Not a
You
single
are.
case.
So you can tell in your hands it is not like that. So that can be done by
Other thing, damage of the endoscopes.
That's
same
part and
endoscope is
parcel
on
of the game.
19. Same
Huh?
endoscope is on 19.
Since Dr. Son, who is the pioneer of UBE,
Yes.
his experiences in every 25 cases, he damages one scope.
I agree with
That's
this. Sir.
why,
I agree with this.
yeah,
Every
and
20 or 30 cases,
that's
I
why,
have to change my scope.
yes, I am using 3D endoscope. It's a costly affair, 1 crore 20 lakhs. It is not possible. Listen, now that's why Son uses Chinese scopes. For demonstration, he uses star scope.
Jayant, how many endoscopes have you damaged till now?
No, sir, expand.
Can you tell why?
I think in full
scope?
endoscopy, the chances of damage are less.
Why?
I'm talking about
monoaxial, they cannot come together unless you keep an instrument open and hit
really,
hard or
really take
bigger.
effort. Exactly.
Catch a big bone pace and hit against the lens.
technique.
Then only it is
I'm
possible.
talking
Instrumental
about
damage
UB.
is part and parcel of our game.
I'm
See,
talking
sir,
about
instrumental damage is part and
UB.
parcel of our game. You talk about UB, you talk about monoportal, you talk about transforaminal, you talk about distando, you talk about easy go. Instrumental equipmental damage is part and parcel of our game, and that depends completely upon the surgeons.
Let me talk to you. In monoportal, the endoscope is angled one, the instruments and the endoscope doesn't touch each other. In UB, that is a problem because you are holding scope in one hand, your right hand is unsupported, but still your instrument has to be in front of the tip of the endoscope. and a small
So even I would
mistake,
like to
you
correct
damage.
you over here. Even in monoportal surgeries, when you're using a burr or using a drill, there's a very high chance that you can damage the lens.
Correct,
Even in
correct,
monoportal
correct.
surgeries,
Not with
Correct.
be it
not with drill,
transforaminal,
Even
but
be
with
it
articulating
RF
monoportal
can
instruments.
interlaminar.
damage.
Articulating
Other
instruments and big bone pieces.
one
So
issue.
equipment damage, even in open surgeries, even in open microdiscectomy or a easy-go system, when you're using a drill, scopic damage is common. So this is equipment trauma. This is bound to happen. Equipment damage is obviously part and parcel of our game.
But in
Rahul, what is the
UB,
cost
it
of your
is more
endoscope?
often. But in
No,
UB,
sir,
it
it's
is
not
more
like that.
often.
It's not like that.
Rahul, what is the cost
I
of your
might
endoscope?
damage couple of scopes second day or
hello,
third day.
please. I think we are overshooting time. And Dr. Rohida, thank you very much.
Muzumdar, one question, one more question.
Okay.
Now
Okay,
in
last
UB, it is a micro one because you are using RF and the endoscope. Have anybody noticed the damage to the glue of the endoscope? Because it is a micro one. And has anybody noticed or reported about the temperature at the site of the dissection? Anybody has reported on that?
So there are papers published on
80 to 90
temperature
degrees.
generation of plasma, on the
The
temperature
temperature of the
generation by
plasma is
radiofrequency
documented
and
in the
plasma.
book.
It's documented in books and papers, countless papers, sir.
How much temperature is there?
Different with plasma and
47 to
different with
52
RF.
degrees. Yeah, it's
40 to
different.
45.
Yes. How much? Because it's a micro one. It is closed cavity. The fluid is hot, and people have reported the damage to the glue of the endoscope.
Sir, I've done more than 400 cases of endoscopy till now, and same scope. It's a very expensive scope. Much I've taken loan for the equipment, and I have never faced any damage to the scope, the soldering of the equipment glue, possibly because they are anticipating this rise in temperature as well. The temperature rise
Yes.
in radio frequency is about 41 to 47 degrees Celsius. With radio frequency, with plasma, it is slightly higher. With
Yes.
bipolar and cautery, it is very hot, sir.
But there is flowing cold water, not hot water. There is no hot water.
But at the site of the
No.
pathology, the temperature is high. People have reported damage to the glue, and this is one of the reason in.
You can feel the temperature on returning fluid when you are using plasma. The returning fluid on your glove is little warmer, so it must be hot there. But when you are using RF, especially WAND, especially trigger flex, then the temperature is very low. It's a very
So it
almost like
is
cold cautery.
very important to use these instruments with pulsatile effect, not continuously. So that will help to reduce, because the new water is coming continuously and it will reduce the pressure,
Very good
temperature.
point. Very good point.
I think
3
thank you very
second,
much.
3
Just
second
last
rule.
question.
1, 2, 3.
Yeah,
Block.
that was mentioned.
Hello everybody. I think we have overshot time. Like I think it is a very fantastic discussion. Now, two things I want to ask. One thing is that after all this discussion, one resident as Dr. Rahul Pandey has asked a very pertinent question to all the panelists and the speakers, actually, not the panelists, speakers. If somebody has to start endoscopic spine, then what system he should start with? Because there are multiple systems, multiple avenues. So all the speakers, please answer this question, which is very valid for the resident. Which system would you start with? These are very short, very short. Yes,
Sir, I
Ranjit.
would
Yes.
Sumit has given a very good slide on that. Sumit has given a very good slide on that. And I can vouch for that after buying cheaper, middle, this, that, struggling for 4-5 years and now starting since last 6-8 months. I can vouch for that slide. I have damaged a transforaminal scope in 4-5 surgeries, disheartened, and then understood that transforaminal is not for our kind of patients unless you are trying to do a small discs and annular fissures and ozone and epidural cases.
Answer is that whatever
Agreed, sir. Completely agreed with you.
I would like to
I damaged my transforaminal scope in the second surgery, and obviously it was very heavy on the pocket.
Yeah, disheartening.
I tried learning the interlaminar procedure, and somehow I was not very fond of it. I may be biased, but I think biportal endoscopy answers everything right from the cervical to the lumbosacral junction. It takes care of stenosis, it takes care of disc, it takes care of extrusions, over the top decompression, redo surgeries. Everything is being taken care of. Fusion, I've been doing lumbar fusions very routinely with biportal endoscopy. So I personally feel that a single stop solution to neurosurgeons and orthopedic surgeons in routine practice is a biportal endoscopy. The cost of equipment is not very high. I mean, you can establish a biportal endoscopy suite for somewhere around 8 to 10 lakh rupees at present.
Thank you. I think we have overshot time. Thank you very much, all the speakers and panelists. It has been a very wonderful discussion, and I should congratulate Sarang, because this webinar has been organized in a very short time in a very critical situation. We are in the end of
Yeah,
December.
sorry for that, Sarang. He had
None
asked
end.
me, and
Also,
I thought I was
Dr.
traveling.
Rohidas asked the question because I think
Yeah,
Sarang must have had a hell of a problem getting, as we discussed earlier. So
yeah,
this is
yeah.
answer for Dr. Rohidas. Probably, maybe inadvertently, he has missed the boss of endoscopy. So I think Sarang, I think with this thing we close this session, and I would return back to Sarang and Milind if they have to say anything for this session. Thank you very much.
So I would like to thank all the speakers for agreeing to present in a short time, and also the panelists to take out the time and for the discussion. So I thank everyone, and I invite all of you for the next webinar on the last Thursday of the next month.
Thank you,
Thank you.
everybody.
Thank you, sir.
Good night.
Thank you
Thank
so
you
much,
very much.
everyone. It was so nice seeing everyone.
Everybody has been
Thanks,
great.
Rahul,
Everybody
Sumit,
has been great.
and Jayant.
Thank
Thanks
you
a
so
lot.
much, sir. Thank you so much for inviting me. Thank you, sir.
Thank you.
Thank you, Rahul.
Yeah.
Thank you, Jayant. Thank you, Sumit.